So, good morning, everybody. Today, we will deal with one of the most common gynecological complaints, that is pruritus vulvae. So, to start with, pruritus in Latin usually means an itch, and vulvae is again in Latin means the external female genitalia, which usually includes the clitoris, the vaginal orifice, the mons pubis, and the labia on both the sides. And this condition usually affects about 1 in 10 women. So, it is a very common complaint. So today we will see what are the various etiological factors that cause this condition and what will be the clinical presentation and how we are going to diagnose and then treat each and every cause of this condition. So if you see the etiological classification of pruritus vulvae, so this can be caused by infections. So mostly it can be because of the vulvovaginal candidiasis, the trichomoniasis, the bacterial vaginosis, the herpes simplex, and even some of the infestations like the pubic lice, scabies, and even threadworms can cause this condition. So infections and infestations are they are the most common cause of pruritus vulvae, and even some of the neoplastic conditions can present to us with this complaint. So most of the times it is the CA vulva or even the precancerous vulval lesions, that is the squamous vulval intraepithelial neoplasia. So they are usually of two types, the usual type and the differentiated type. So the usual type usually it presents or manifests in the form of warty lesions or a basiloid lesion, or sometimes it could be mixed. And then we have this differentiated type. So in both these conditions, pre-neoplastic conditions, they can present to us with pruritus. And some of the non-squamous conditions like the Paget's disease and even some of the tumors of melanocytes also can present to us with this pruritus. And and then we have even the hormonal causes of pruritus vulvae. So one is the atrophic vaginitis that usually we see in the postmenopausal woman. So because of the deficiency of hormones, especially the estrogen in the postmenopausal lady, most of these women can present to us with atrophic vaginitis and with the common complaint of pruritus vulvae. And again in women who are breastfeeding, again because of lack of estrogen, so these women are prone for atrophic vaginitis leading to pruritus vulvae. So even we should think of these hormonal causes as well. And this complaint can also be secondary to either a urinary incontinence or sometimes even a fecal incontinence. And a few of the causes could be because of the systemic causes. So sometimes they are secondary to some renal pathology, so especially after a chronic renal failure. And a few of the causes are secondary to the hematological conditions, so particularly the iron deficiency anemia, or it could be even the polycythemia rubra, or else hypereosinophilic syndromes or essential thrombocytopenia or myelodysplastic syndromes. And few of the causes could be secondary to the liver conditions. So most often this obstetric cholestasis is usually seen in pregnancy, right from late second trimester to third trimester. So again in pregnancy these women usually comes to us with intense itching, and but then we don't find any rash. So hepatic causes could be the cause of pruritus vulvae. And few of the endocrine conditions like either hyperthyroidism or hypothyroidism or even diabetes mellitus or even thyroid parathyroid conditions can also cause this pruritus vulvae. And a few of the malignant conditions like Hodgkin's disease, leukemias, carcinoid syndromes, and immunosuppressive conditions. So these, because of the immunosuppressive states, they lead to vulval vaginal candidiasis and thereby leads to discharge and itching. So, and then the other causes could be rarely because of the psychosexual disorders or else because of the regrowth of the pubic hair after shaving. So these are all the etiological factors causing this condition. So coming to the causes of pruritus vulvae in different age groups. So we need to think of specific causes depending upon the age group. So if it is a prepubertal girl who is coming to us with this complaint, so we should either think that it is because of the poor hygiene, or it could be because of the streptococcal infections or the E. coli infections. And most of these girls are more prone for these infestations as well, especially the pinworms or even the scabies. And it could be even because of the allergic contact dermatitis because of the usage of certain products. So in prepubertal girls we need to think of these causes, whereas in young women in the reproductive age group, so mostly this because these women belong to reproductive age group, they are more prone for STIs and then causing vaginitis. So either a trichomonas vaginitis, especially, or else because of the usage of certain products, can be because of the allergic contact dermatitis, and even Lycus simplex chronicus and hydradenitis suppurativa tend to be also common in these age group women. Whereas when it comes to the postmenopausal woman, so as we have just discussed, these women because of the estrogen deficiency, they can have atrophic vaginitis having this symptom. And then even the lichen sclerosis, so these are considered to be again a pre-malignant condition to vulval cancer. So because few of the cases can turn into malignancy, so in this age group we even need to think of either a lichen sclerosis or even vulval cancer or Paget's disease. And very rarely in these women they can be candidiasis, especially if they are a woman is a long having long standing diabetes or some immunosuppressive condition, or else few of the dermatophyte infections can also be the cause of pruritus in this age group. So depending upon the age we need to think of the various etiology of this condition. So coming to the sorry. I think I need to. So coming to the pathophysiology of pruritus vulvae, so it is either an acute or chronic condition. So this sensation of pruritus is usually transmitted through the C fibers to the dorsal horn of the spinal cord to the cerebral cortex via the spinothalamic tract. And this pruritus usually generates a spinal reflex response, that is usually the scratch, which is as innate as a deep tendon reflex. And then this is often exacerbated by skin inflammation and because of the dry or hot ambient conditions, or because of the skin vasodilatation, or because of the psychological stressors. So this is the pathophysiology of this cycle, itch scratch cycle. And then what are the mechanisms in acute presentation? So in allergic, especially in allergic dermatitis, it is because of the histamine that is released from the mast cells that is the cause of pruritus. And whereas if it is an atopic condition, that is the atopic vulvitis, usually these are the cytokines and the immune mediated pro-inflammatory agents that are involved in this condition. And if it is because of a viral infection like herpes simplex, so it is because of the nerve paresthesia. And then in certain conditions like polycythemia or in uremia or in cholestasis or in lymphoma, so in these conditions the serotonin mediated pruritus occurs. So the pruritus is secondary to the release of serotonin. And Coming to the most common clinical presentations and what are the possible clinical diagnosis in those presentations. So if any woman has an itch associated with soreness, excoriation, ulceration, as well as a certain amount of skin scaling and whitening changes, so we need to think of either a psoriasis or could be because of leukoderma or lichen sclerosis or planus, and even infestations like scabies and intertrigo. And if it is an itch and discomfort, particularly if it is not at all well controlled, so recurrent episodes of this itch and discomfort associated with vaginal discharge, so we need to think of diabetes. And itch and soreness, so only itch and some amount of soreness, so we need to always think because of the allergic dermatitis. So this allergic dermatitis can be secondary to the usage of various products, especially either a particular kind of soaps or deodorants, or even allergic to sanitary wear or usage of detergents, or sometimes even to certain fabric conditioners. So itch and soreness, we need to think of always allergic dermatitis. And if the vaginal discharge associated with itching, so we need to especially think of two conditions. So it could be either because of the trichomoniasis or because of candidiasis. So usually in candidiasis we find that there is intense pruritus and vaginal discharge, and we when we examine the woman, usually we find that there is whitish or creamish white discharge. Whereas in trichomoniasis, again the woman comes to us with intense itching and vaginal discharge, and then the discharge tends to be greenish yellow or sometimes even a greenish discharge. And when we examine the woman, we find that there can be certain spots on the cervix causing or leading to strawberry cervix. So any vaginal discharge associated with itching, we need to think especially of these two conditions. And sometimes psychosomatic conditions can also present with this condition, so whether mental stress or sexual anxiety in the absence of physical disease. So most commonly this tends to be again common in younger age group. And then the correlation between the clinical appearance of the vulval lesion and its pathologic features. So if you see the clinical condition, the patterns, and then the pathologic correlates. So if it is a spongiotic pattern, we need to think of either an atopic or allergic or an irritant dermatitis. If it is showing an acanthotic pattern, so we need to think of either it could be because of the psoriasis or the lichen simplex, and then even the lichen sclerosis. So it is usually the acanthotic pattern. If it is a lichenoid pattern, we need to think of either it is a lichen planus or a sclerosis. And in lichen sclerosis, apart from the lichenoid pattern, we find that in the dermal area there is dermal homogenization or even sometimes a dermal sclerosis pattern that is very typical of lichen sclerosis. And if the lesions are vesiculobullous pattern, so we need to think of either a pemphigoid or a linear IgA disease. And acantholytic pattern, so it is acantholytic pattern, usually is seen in Haley disease or Darier's disease. So these are the clinical conditions or the patterns which these lesions present to us, and then these are the pathologic correlates. And then the granulomatous pattern is seen in either Crohn's disease or Michelson-Rosenthal syndrome, and vasculopathic pattern is seen in this aphthous ulcers and Behçet's disease or plasma cell zone vulvulitis. So whenever a woman has these complaints, so what should be our clinical evaluation? So in the gynecological history, we need to take in detail what is the duration of the presenting symptoms, and then the severity of these symptoms. So whether they're mild, moderate or severe. So the severity of these symptoms and what effect they have on the quality of life. So and then apart from that, apart from the history related to pruritus and the discharge, so we need to even ask them about the medication history, because few of the medications might cause itching as well, or else it could be because of her complaints the woman may be put on certain medication. So we need to even take the medication history, and then the personal or family history of certain autoimmune conditions, and whether again she has a personal or family history of atopic conditions, and then whether she has any urinary incontinence incontinence or a fecal incontinence, because again sometimes these could be the causes of her complaints. And then the smoking history and cervical smear history, particularly if the woman is of reproductive age group woman and the postmenopausal woman. And then what effect or what impact these symptoms have on either the sexual life or psychological and social life. And once the history is done, we need to thoroughly examine the patient. So the full examination of the anogenital region apart from the skin and mucous membranes. See, because few of the conditions not only infect the anogenital region, they can even the lesions can be seen on the other parts of the body, so especially the mucous membranes. So we need to examine thoroughly not only the anogenital region but the whole of the skin and the mucous membranes. So coming to the investigations, so based on the history, based on your examination findings, we need to direct what investigations this woman particularly needs. So we need to either go for thyroid function tests, or if we think in terms that she may be diabetic because of recurrent episodes of these complaints, we need to even screen them for diabetes mellitus. So if the history suggests to of sexually transmitted infection, so we need to screen for STIs. And then the skin patch test if we are thinking in terms of any allergic dermatitis. And then again, if you are thinking in terms of pre-malignant or pre-neoplastic condition, or even if you are suspecting a carcinoma, the vulval carcinoma, so we need to even take a biopsy, so vulval biopsy. So the investigations will be done based on your history and examination findings. So what are the general measures that we need to take? So the practical tips, what do's and what don'ts we need to implement. So we need to always advise these women to use a soap substitute, take a shower instead of a bath, and gently dab the vulval area. And then they are not supposed to use any sponges or flannels. And then once after taking a shower, we need to dry with a soft towel or hair dryer on a cool setting held away from skin, not directly or very close to the skin. And then it is better always to wear loose fitting garments or loose fitting underwears, preferably a cotton underwear. And then the don'ts usually include we need to always advise them to avoid conditioners, fabric conditioners, or washing powders, certain soaps, because some of the products may cause allergy and lead to allergic dermatitis. And then these women should be advised to sleep without underwear, and then they are supposed to even wear light colored clothes. And then the don'ts include usually to avoid colored toilet paper, and then the panty liners, and then the dark colored garments. And then the complications. So what if this condition is not treated? So particularly if you are suspecting either it is a lichen planus or a lichen sclerosis, there is always a 5% chance of these lesions turning into malignancy, that is squamous cell carcinoma of the vulva. And intense itching and intense itching so can lead to insomnia, and thereby these women are prone to somnolence, and again this can lead to occupational hazards. And then repeated scratching or repeated scratching usually leads to skin breakdown, and these this will cause secondary bacterial infections. So these are the complications that we usually expect once any woman has this condition. And then the clinical presentation and treatment of the causes of pruritus vulvae. So we are talking of this vulval intraepithelial neoplasia. So the clinical presentation of these women will be usually an intractable itch. And this VIN can be of two types, that is the usual type and the differentiated type. So the usual type are usually because of the viral infection, that is your HPV, human papilloma virus. So these lesions tend to be warty or basiloid, or sometimes a mixed lesion is seen. These neoplasia, this pre-neoplastic condition is usually seen in women aged between 35 to 55 years. So coming to the treatment of this type, we either go for the topical imiquimod cream, which is an immune modulator, or sometimes few of the lesions can be excised. So surgical excision usually is advised for VIN 2 and 3 lesions. So when it comes to the differentiated type, so this differentiated type is because of the associated other skin lesions, especially the lichen sclerosis or a lichen planus. And usually these lesions tend to be a single lesion, either in the form of, they present to us in the form of either an ulcer or a plaque. And this is most commonly seen in women aged 55 to 85 years. A bit elderly women are prone for this type of VIN. So whereas the usual type tends to occur in the middle age group, whereas the differentiated type tends to occur more often in postmenopausal women. So because of the associated conditions like lichen sclerosis and planus, there is always a chance of turning into malignancy. So these lesions always need a follow-up annual surveillance. And then coming to the cause, either it could be an atopy or allergy or irritant or seborrheic dermatitis. So the clinical presentation will be if it is an acute condition. So the woman presents to us with a red rash, sometimes associated with swelling, and we can always see blisters or papule formation. And if it is tends to be chronic, so the lesion tends to be like a fluid, and then it becomes ill defined. It has an ill defined border, and some amount of scaling is seen, and then the other sides may be involved as well, especially the axilla, the eyebrows, sometimes even the nasolabial folds can be seen. So in case of severe or uncontrolled symptoms, usually it is always go for a patch test. So the treatment usually includes the avoiding irritant agents. And so first thing is we need to stop or avoid these irritating agents, and then the general measures has to be adopted, like we have just discussed what are the do's and don'ts. And apart from these general measures, so these women mostly require usage of topical steroids, that is 1%, hydrocortisone 2 to 4 weeks, and then we need to always review the woman whether these lesions are improving or not. So and then if the lesions tend to be chronic, so these women most often require a long term usage of steroids. And then to break the cycle, the itch scratch cycle, so these women apart from steroids they need even antihistamines, so to prevent particularly the nighttime scratching, so that they can have a good sleep. So this is the treatment for this atopic or allergic conditions. So coming to the lichen sclerosis, so usually again this condition tends to present with severe itching, particularly at the nights. And if you see or if you examine the perineal area, these typically have an figure of 8 distribution. So figure of 8 distribution will be seen involving the perianal area, and then white plaques, sometimes papules, and here and there will be areas of bruising. And these areas usually will be seen on the labia minora, or sometimes on the clitoral hood, or on even on the clitoris, or the perineal body, or even the perineum. So especially these are the sites where these lesions tend to occur. And then the intense itching usually may lead to scarring, and over a period of time even the introitus tends to be narrowed. And particularly we are concerned about the chances of turning into malignancy, because there is always a and then a weekly treatment. So usually this treatment should usually runs into 3 months usually. So if a woman is not responding to the first line agent, that is the clobetasol propionate, so then we need to go for the second line management. So the second line treatment usually involves the calcineurin inhibitors and tacrolimus. So usually these agents also are very effective in treating these lesions. So but remember, the first line of treatment is always the steroid, that is 0.5% clobetasol propionate. As the nails, unlike the lichen sclerosis. So in lichen sclerosis it is only the perineal area that is involved, whereas in lichen planus the lesions tend to be seen in other sites as well, so mostly in the nails as well as on the buccal mucosa. So the lesions are a bit bluish purple, shiny, flat top papules, and you find the small white dots or lines. So these are labeled as Wickham striae. So Wickham striae is characteristic of the lichen planus lesions, and there is always again the chance of turning into squamous cell carcinoma. So again these women with this condition needs to have a careful surveillance. So the treatment involves usage of 0.025% betamethasone valerate cream, either in the form of cream or an ointment twice a day. So this is the treatment for lichen planus. So coming to the lichen simplex chronicus, so again the woman will have intractable itch, particularly at the nights. So when we examine these women, the plaques will be very thickened, and then we have the skin markings tends to be very exaggerated, particularly over the the labia majora, and sometimes the mucosal vulval skin and the labia minora may be spayed. So this condition usually presents with intractable itch, particularly at nights. So the treatment involves the general principles or the general measures that we usually should take, and then the emollients should be avoided. Instead, soap substitute has to be in place, and then we need to avoid the irritants, and antihistamines and antipruritics agents usually will be of help in this condition, apart from the usage of steroids. And then the other conditions are the psoriasis. So you know well that this lesions of psoriasis will have a well demarcated border, and then absence of scale when affecting the vulval area, and then they can be, the lesions tend to be smooth pinkish lesions, and sometimes even the nails and scalp may be involved as well. So apart from these areas, so the treatment usually involves usage of emollients, soap substitutes, and then vitamin D analogs, apart from the steroid creams. And sometimes even coal tar should not be used, particularly with these lesions. So it is usually the steroid treatment, the vitamin D analogs, that are usually form the treatment for these lesions. And then the most common infestations that cause pruritus vulva include the threadworms. So the patients or these girls usually comes to us with again intense itching, particularly around the anal opening, and these lesions tend to spread over to the perianal or the vulvovaginal area. And particularly this intense itching is more noticeable, particularly at nights. So the treatment usually involves mebendazole 100 milligrams oral start dose. In case if there is any reinfection, so we need to go for another second dose. So the treatment, the management plan for the thread form infestation is usage of mebendazole. And if it is this pubic lice, that is if you find nits in the pubic hair, so we need to use 0.5% malathion lotion or 1% linden lotion, or applied to the pubic hair for 12 hours, and then it has to be washed off. So again this same thing has to be repeated after a span of 7 days. So that's how we treat pubic lice or nits in the pubic hair. And then the viral warts. So for the viral warts, of course usually a bit rare, this the treatment involves going for a cryotherapy or usage of podophyllin once a week, and then once we apply this podophyllin, it should be washed off after 4 hours. And again if it is a scabies, so you know very well that it presents as the formation of burrows alongside of fingers and in front of the wrist. Typically this is the presentation of scabies. So the treatment involves usage of zinc pyrethron or malathion lotion or cream, and it has to be applied on the whole body, so of course, but not the scalp face. So it has to be given for 2 successive nights, and then oral ivermectin can also be used for this condition. And herpes simplex, you know, because it is a viral agent, so we need to give them the oral antivirals. So oral acyclovir, the dosage is 200 milligrams 5 times a day for 5 days. So this is the treatment for primary herpetic infestation. Whereas if it is a recurrent or a secondary episode of this virus, so oral cyclovir 400 milligrams BID for few months has to be given. So once it is think of, if you're thinking in terms of it is herpes simplex, we need to even screen these women for other STIs as well. And then the typical the infestations, trichomonas vaginalis, as we have been discussing, it is the woman will have a frothy greenish white discharge, and then when we examine the smear, it shows that the presence of flagellated protozoa, that is trichomonas vaginalis. So the treatment usually given is metronidazole 400 milligrams twice daily orally for 5 to 7 days, or else we can go for a start dose, that is 2 grams of metronidazole. And if it is a bacterial vaginosis, the patient will have typically a fishy odor vaginal discharge. And when we see the wet mount, it clearly shows the presence of clusels. So these are the characteristic lesion of this bacterial vaginosis. So the treatment again involves the same, that is metronidazole 400 milligrams orally twice a day for 5 to 7 days. And then the partner has to be simultaneously treated for both the trichomonas vaginalis and the bacterial vaginosis. When it comes to candida, the lesions tend to be this erosions on sometimes on the vagina, apart from the creamish or white thick discharge that we see. And then when we examine under microscopy the discharge, we find the hyphae and the spores. And we need to always rule out whether the woman is diabetic or whether she has any immunosuppressive condition. So the treatment involves going for antifungals, either a local application of either miconazole or nystatin or clotrimazole cream, or else even the oral antifungals will also help. That is the oral fluconazole 150 milligrams usually we give once a dose, or if it is going to be recurrent, we need to give every week for few months. So we might consider even treating partner in this condition. So I think it is clear this pruritus vulvae is a common clinical complaint that most women will have. So we need to think of what are the various causes that cause this condition, and the causes again depends upon the age group. So when a prepubertal girl comes to us, what are the causes we need to think? Whereas if it is a postmenopausal lady, we need to always think in terms of either a pre-neoplastic condition or a vulval neoplasia. So it all depends upon the age group. And if a woman of reproductive age group comes, so we need to mostly think of STIs. So depending upon the age group, we need to know what is the etiological factor, and depending upon the history, depending upon our examination findings, we need to direct what investigations she needs, and then the treatment has to be directed depending upon the cause. Okay, thank you.
The recording.